Thank you everybody for coming today. I'm Dr. Schmidt. I'm a gastroenterologist at Granite Peaks Gastroenterology, which is just across the parking lot over here. Today's talk is about dysphagia. Dysphagia is a term that refers to difficulty swallowing. And this dysphagia or difficulty swallowing has different forms. So for example, it can represent a difficulty initiating the swallow function, or it can represent having that food passed down into your stomach. And so we'll touch on primarily that second one, but first a couple of definitions. Dysphagia is the subjective sensation. When you feel a difficulty with swallowing, or there's some abnormality that you notice or perceive that's causing difficulty swallowing. Odynophagia is the term for people who have difficulty or pain when swallowing. So sometimes people feel as though they can swallow okay, but it's actually painful. It hurts when it goes down. So that tends to represent a slightly different problem. The third category is what's called globus sensation. Now, globus sensation is the sensation that you have something stuck in your throat, or you feel a lump in your throat, a baseball or a golf ball is stuck in your throat feeling. But after an evaluation, a medical evaluation, it's not actually due to a structural abnormality like a tumor or a stricture or anything else. So those are the major categories, and we're going to focus primarily on the first one, which is dysphagia. So as I mentioned briefly at the beginning, there are two broad categories of dysphagia. The first is called oropharyngeal dysphagia. Now that represents a problem initiating the swallow. So it frequently is associated with other symptoms that would tend to suggest this problem. So when you were to go to swallow, what might happen is, if, for example, if you're swallowing liquids, some of those liquids may actually feel like they go upstream. They go up into your nose, or you may get the sensation where you're coughing, where it's going down the wrong pipe. And so that can be an issue with what's called oropharyngeal dysphagia. People sometimes will also have difficulty handling their secretions. So they may have a wet quality to their voice. Another part of the history that is helpful when I'm talking with people in the office is if they have issues with a runny nose or a cough while they're eating. So that tends to be an issue that suggests difficulty with initiating the swallowing mechanism. So if you've had a stroke, you lose the ability to swallow sometimes, and stroke affects, as you know, affects skeletal muscle. So people can have an eye droop, or they can have their face droop, or one side of their body doesn't work appropriately. And so the swallowing mechanism that involves your tongue, it involves your throat muscles. Those are skeletal muscles, or some of them are voluntary muscles. And so when you have issues with a stroke where it impairs that ability, you'll tend to have problems with the initiation and coordination of the swallow mechanism. The second broad category is esophageal dysphagia, which the rest of this talk is going to be about. This is actually difficulty swallowing several seconds after you feel like you've swallowed. And so you swallow, and then a second or two later, you start to notice that something's not right. So it'll feel as though something is either stuck, or you feel like your throat has closed off because the food that you just swallowed hasn't gone down. And so that's considered esophageal dysphagia. When I'm asking people questions about swallowing in the office, there are some things that you want to know. I'm trying to figure out what's going to help you the most, and how are we going to figure out what's going on. So the things that help are to know whether the swallowing is for solid food, for liquids, or is it both. Some people have difficulty with just solid food, and some people have just liquids, and then there are people obviously who have both. The other important part of the history is if your symptoms are getting worse over time, or if this is something that you swallow fine most of the time, and then randomly just one day you'll have a problem swallowing, but then the next day you're fine. And so that would be an intermittent type problem. Other parts of the history that are helpful that I'll sometimes ask are, what other symptoms are you having that are part of this? Do you have heartburn? Heartburn is something that people think of as a nuisance sometimes, where maybe they take Tums or Rolaids, but heartburn is important because heartburn leads to inflammation, ulcerations in the esophagus, which can impede the transit of food or liquid through that area. Heartburn is also the risk factor for esophageal cancer. And so esophageal cancer is actually on the rise in the United States, and so that heartburn is a very important topic. Other symptoms would be weight loss. If you're losing weight for no reason otherwise, then that's obviously not a good sign. That tends to suggest that there's a serious problem going on. Vomiting blood, so if somebody obviously is bringing up blood because the food is getting stuck, that's a problem. It definitely tends to suggest one cause versus another. So we're going to talk first about difficulty swallowing solid foods only with intermittent symptoms, meaning that some days you may swallow just fine, other days you're having a problem. And so the most common condition that causes that is something called allergic esophagitis or eosinophilic esophagitis. Now this is a field or a disease that has really mushroomed over the last 10 to 15 years. It used to be a disease strictly of the pediatric population, so adults really didn't have this problem, but more and more people seem to be developing allergies, and it's happening later in life. So the two pictures that I have on the right-hand side of your screen there, the first picture is a normal esophagus where the yellow arrow there that you can see towards the bottom is pointing to what looks like normal esophageal mucosa or lining. So everything there looks just fine. The white arrow, which is more at the 9 o'clock position, is pointing to gastric tissue, so that's the junction. So what you're seeing is the junction between the esophagus and the stomach. And that's a very important junction because that's where people tend to develop problems with acid reflux and strictures and things of that nature. But so picture number one there with the arrows is a normal esophagus. Picture number two, I don't know if you can tell, but there are kind of white spots or plaques that are on the mucosa. It also gives you the impression that there are rings or ridges going down. It looks kind of corrugated almost. That's not normal. So those white plaques are an example of an inflammatory process that's happening, an allergic process that's happening, and it's getting so overwhelming in that specific location that you can see it visually with your eyes. And so if you were to take a biopsy of those white spots, they would be a type of cell called an eosinophil, which is what the diagnosis or the disease is named for. And so basically, eosinophils are allergic inflammatory cells. And so if you have an allergy, those cells are going to be higher than normal in the biopsy. And so that is by far the most common reason that I see somebody who has difficulty swallowing. It's the kind of thing that I go into the hospital to see people at night because they were at Cafe Rio and got some pulled pork stuck, or they got steak or something stuck. because this affects people of all ages, and it'll happen just kind of suddenly out of the blue, where they'll be having dinner with friends or family, and their first bite or second bite just doesn't go down, and so they have this horrible sensation where they can't swallow. They're salivating like crazy. They try to swallow water to get it to go down. It doesn't go down. They try to retch and bring it back up, but it doesn't come up. And they've got this intense pressure in their chest. And that's that's the manifestation of this, what we call a food impaction. So the food actually wedges like a cork in a bottle in your esophagus. And that can be a very uncomfortable feeling. By far, that's the most common reason for me to go in to the hospital at night, which is kind of weird. I never thought that that's what I would be doing, is pulling out chicken for a living. But that's the way it is. The next category for the solids intermittently is something called an esophageal web or ring. A web is typically something that's very high up in the start of the esophagus. These are congenital, and they're not related to acid reflux or allergies or anything like that. It's something that can be treated very easily with endoscopic techniques. So this is the next category, which is difficulty swallowing solid food with slowly worsening symptoms over time, progressive symptoms. And so you can see from the picture over here, this is not good. So typically when somebody has slowly worsening symptoms, the major thing that you're worried about is obviously cancer. So esophageal strictures can also do this. So a stricture is a broad term or generic term for something that's narrowing the lumen of the esophagus. And that can be related to acid reflux, which is probably the most common. So as I mentioned before, acid reflux causes inflammation, and then that inflammation over time causes scar tissue. And that scar tissue, it tends to narrow down the lumen, and so therefore the diameter of your esophagus is much smaller. And so what a normal person would be able to swallow tends to get stuck in that area of scar tissue. People who have had thyroid cancer or any other head and neck cancer where one of the treatments that they received was radiation can have upper esophageal strictures due to radiation damage. And that's not as common these days as it used to be, because the radiation is able to be more focused and is a little bit milder these days. But in the past, people who had head and neck cancers or thyroid cancer, or even a thymoma, they were called a chest malignancy, they would get radiation as part of the treatment. And then that radiation years later would cause strictures in the esophagus, which are very difficult to treat. The last one obviously here is cancer, and this picture shows somebody who has esophageal cancer. You can see how that's a very abnormal picture. The top part of the pink part of the sorry if I'm blocking you. The pink part is the normal esophageal tissue, and then that red kind of ulcerated white stuff that's very abnormal is esophageal cancer. And so this is the type of cancer that people tend to develop is called adenocarcinoma. This is the same kind of cancer as, so adenocarcinoma happens in the colon, it happens in the stomach, it happens other places as well, but adenocarcinoma is the most common type of esophageal cancer. And it is, the risk factor for esophageal cancer is acid reflux or heartburn. So unchecked, that's a problem. So there are different treatments, of course, for things like this. Sometimes surgical removal is the best option. Sometimes radiation to the esophagus works well, and then sometimes chemotherapy. Because the esophagus doesn't go anywhere, it's relatively fixed in your body and position, radiation therapy is something that we'll frequently use to treat people before they get any other treatments for esophageal cancer, because you can basically try to kill that tissue with the radiation beams, and that can work pretty well. So now the next category is a difficulty with liquids or solids, and sometimes both. Now, the hallmark of this condition is something called achalasia. Achalasia is a motility disorder, so meaning that the motor function, the muscles of the esophagus don't work the way they're supposed to. And so the picture on the right is an X-ray called a barium esophagram, or a barium swallow. Some of you may have had one of those, where what people do is you drink some contrast, and then while you're drinking this liquid slurry, the technician takes X-rays of the liquid as it's going down through your chest. And what you're supposed to see is kind of like a nice narrow tube that empties into the stomach, and without any obvious, filling defects or blockages. But what you see over here on this picture is that that nice tube up top empties into this big, huge space, the black space, and then it kind of narrows down very abruptly into this tiny little thing that almost looks like a bird's beak, is what you see in somebody who has this condition called achalasia. So what this represents is a loss of the contractility, the muscle contractions of the entire esophagus. So the muscle doesn't work. The esophagus is not a chute where food just slides down. It has to get pushed down. And so the contractions start at the top, and they push the food all the way down as it's going down. And then there's a muscle at the bottom called the lower esophageal sphincter. That's a circular muscle that is normally supposed to stay relatively tight and closed to prevent you from having acid reflux up. And so when you swallow, the normal thing is the muscles go down and contract, and then the lower esophageal sphincter then relaxes at the correct time to allow that food to pass into your stomach. But in this condition, that lower esophageal sphincter is continually tight. It doesn't relax, it can't relax, and it's just basically locked down. And so what you have is you have a weak muscle up top that can't contract, and then you have the gate at the bottom is closed. And so those poor people have a really hard time. And so what happens is they eat okay, they get food in, but then it just fills up into this big cavity that is their esophagus. And so those people will frequently have problems with heartburn because they feel like there's liquid kind of washing up all the time, which it is, because it's just sitting there in a sac in their chest. And they also obviously have difficulty swallowing. There are other motility disorders that have kind of fancy names. The one that I like is the jackhammer esophagus, which basically it's where the esophagus just, instead of it being a nice propagation from the top all the way down in a sequential fashion, the whole thing just squeezes at once. And then people get intense chest pain as that's happening. But again, that's not an effective way to get food down. The one that tends to be common as we age is a condition called the presbyesophagus. Presbyesophagus is basically where it's not like achalasia where the muscles don't contract and then there's tightness at the bottom. It's just kind of old and doesn't work very well, and your muscles aren't very strong. And so it kind of works, but kind of doesn't work. And so sometimes people they'll not even really know that they don't swallow normally. They just eventually they'll say, oh, I'm drooling a lot, or the food's coming back up when I lie down, and that's because they have the entire day's meal basically in their esophagus because it just didn't go down. And so those are really challenging to deal with, because if you can imagine, if you have a whole column of liquid and food and things like that, and then you lie down to go to bed at night, it's all just going to come right up and you're going to choke and gag, and it's going to be very uncomfortable. And the only way to resolve that issue acutely is to go down and pull it all out, to get all that food out endoscopically, which is very challenging and sometimes dangerous. So the next step that we've kind of gone over a little bit already is how do I evaluate somebody when they come in saying that they have trouble swallowing or they have some of these other symptoms. In the old days, the gold standard was definitely the barium esophagram, and you can see a picture of that on the far right. And essentially that's the x-ray where you drink liquid and they take a kind of a dynamic x-ray where they're watching how the esophagus is working and where the liquid is going. That's a non-invasive test, and so for example, if somebody is elderly or they have a lot of medical conditions that make me nervous about them, I might do a barium esophagram as the first step in evaluating what's going on with their swallowing. It gives you a nice roadmap as far as is there a stricture there, is there a tumor there, is there a hiatal hernia, you know, what does the roadmap look like? It doesn't tell you, it doesn't give you the option of biopsying anything. You know, if you were to see something, you would still have to go further and try to do additional tests. It doesn't allow you to do anything. You can't treat anything with the barium esophagram. It's just a diagnostic study. The next is the upper endoscopy, which has really become one of the main tools that we use as gastroenterologists to evaluate people who have all types of upper intestinal symptoms. But essentially, you know, this is very much like a colonoscopy except from the other end. You know, you're sedated for it. You put a flexible scope that has a camera and a light, and you can look at every structure from the vocal cords down to the upper esophageal sphincter to the length of the esophagus. And then this picture, the kind of the pink picture there, what this shows is an esophageal ring, or something called a Schatzki's ring. So if you're able to appreciate, it's a nice crisp circle there, but it looks a little bit smaller than what's above it and what's below it. And that's a scar tissue ring that's associated with long-term acid reflux. It's benign, but it doesn't allow for the esophagus to expand. If you were to eat a piece of chicken, that chicken could get stuck right there because it doesn't get bigger, it just stays the fixed size. So these little notches, these little black notches, that represents where the ring is, and you can see how the lumen is narrowed. So here's the normal lumen, but then you have like this area that's narrowed, and that represents the ring. And so if there's a piece of chicken stuck there, you can obviously understand why that's going to happen. The third modality that we use to evaluate somebody who has trouble swallowing could be what's called an esophageal manometry. So that's basically where you test the strength of the muscles. So as I mentioned before, the esophageal body, what it does is it contracts starting at the top, working its way down, and that should happen in a sequential fashion. And so you want to see contraction, 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 and then relax at the bottom to allow food to go into the stomach. And an esophageal manometry can tell you whether that process is happening. Out of these tests, these three tests that I have on here, the esophageal manometry is without a doubt the most uncomfortable. So you're awake, they put a tube in your nose, and that long tube goes down into your stomach, and the tube has balloons on it, you know, different lengths along the tube. And the technician inflates those balloons, and then they ask you to swallow water. And so what those balloons do is they're attached to a recording device where it measures the pressure that your esophagus, the muscles, are generating. And so if your esophagus is normal, it'll be able to say, yeah, the pressure was normal, they have the normal contractility that's supposed to, or it doesn't. And so that test we use often. Esophageal manometry can also be used with, they have kind of what's called a high resolution manometry now, which gives you nice kind of pretty color images that are appealing to the reader's eye to be able to tell whether this is a good strong esophagus or whether it's weak or ineffective. And that's pretty much it as far as what I have for topics to present. If you guys have any questions, I'm happy to answer any questions that I didn't maybe address here. There's no limit. So basically, if you have a problem that needs to be resolved or treated. There's no limit to how many times you can have that done. It really depends on what the issue is, what the condition is. So for example, if it's a reflux-related stricture, sometimes, in addition to treating the underlying reflux with omeprazole or some sort of acid-reducing medication, sometimes people's body just tends to form strictures, and that can be very difficult to treat. So you may hear a story about somebody who had an esophageal stretch or dilation once, and they were good for years, and then you have other people who may come back every month or every couple of weeks until you get it open to a certain size. And so every situation is very unique, but to have multiple dilations is certainly standard if needed. So there are two broad categories of the allergy. One is an environmental allergen. So there was a study that was done in probably 2006 where they looked at the distribution of eosinophilic esophagitis across the United States. And it happens everywhere in the country, but it's definitely more common in kind of what they call the desert Southwest. So Arizona, New Mexico, Utah, Nevada, places like that, Texas. It's very common here, but it happens everywhere. And so there's definitely an environmental component. There's also a food-related component. And so the four most common food groups that are triggers for eosinophilic esophagitis are dairy, wheat, soy, and nuts. Those are the four most common food groups. And so typically what we'll do is we'll treat people medically and endoscopically for the allergy, and then to relieve their swallowing issue. But then the more long-term question is, what do you do to prevent this? And so then we'll send people to an allergist to try to identify what their specific allergy might be, and then they try to eliminate that from their diet. So yeah, it's definitely a diet type thing. So allergies are hereditary in the sense that families who tend to have asthma or allergies are more likely to have conditions like this. So you may have a family member who has asthma and somebody else has this condition, or so they tend to run in families. Things that could potentially, things that you might have at home that might help would be room temperature water. You want to avoid hot liquids and cold liquids. You want something that might relax that contraction. But there's not really anything else, that you could do on your own without medications, let's say, to relax that spasm. There are definitely medications that can help, calcium channel blockers and medicines like nitroglycerin, which people also use for heart problems and blood pressure medications. There are smooth muscle relaxers, so they will relax that smooth muscle. The top of your esophagus is skeletal muscle, the top third, and the bottom 2/3 are smooth muscle, so involuntary muscles. And so you can't kind of will yourself to relax it. And so it's basically, it has to either play out or you have to take a medication to calm it down. We have people that we see in the hospital where they'll have come in with a stroke, a new onset stroke, and it's not safe for them to swallow because they aspirate, And so as the stroke recovery, as you do physical therapy, for example, for your left leg and your left arm, you'll also meet with a speech therapist or speech pathologist to do physical therapy for swallowing. And so there are different techniques that this therapist will use to allow you to swallow safely so that you're not aspirating on liquids usually. And so physical therapy works. There are certain swallowing techniques So for example, people will do sometimes like a double swallow, where they'll swallow once and then swallow again to get any residual liquid that may be left in the back of your throat to get it to go down. So that's something that people, the therapist will have people do. Changing the consistencies of your food that you eat is also something that will help with difficulty swallowing after a stroke. So for example, somebody may not be able to drink thin liquids again. Water, juice, milk or soda or anything, because it's harder to handle thin liquids than it is something thicker, like pudding. And so sometimes they'll put in thickening substances like pectin. It thickens up the liquid, and then they are able to handle that better without it getting into their lungs. Eating early, as opposed to eating before bed. So we like to have people have 3 hours from the time that they finish eating before they go to bed, so that they are not lying down with food in their stomach and therefore allowing for acid reflux. If you have reflux or heartburn, you should address it with your physician so that it's being treated, so that you don't develop any of these more serious or even the reflux-related stricture conditions. So it's basically healthy eating, healthy lifestyle, and exercise is definitely part of those. So prevention is way better. But again, I think there's a little bit of public education about reflux. People think reflux is reflux, it's heartburn, who cares? And they tend to ignore it a little bit, and then it progresses, of course. So. What's called a modified barium swallow. And so that is, it doesn't give you just a roadmap, it gives you more of a functional, it's a more functional test. So for example, the speech therapist will be there, the pathologist will be there with you, and they'll test different liquids. So they'll start off with a thin liquid, this white contrast stuff. They'll start off with a thin consistency, and then they'll watch you drink it, and they'll see what happens in the back of your throat. Is it just pooling in the back of your throat? Are you having a hard time getting it into a bolus to swallow? Is it going into your esophagus, but then some of it is going into your lungs? So they'll start with that, and then they'll progress to more thicker consistency like pudding or applesauce, and then they'll even do it with solids. And so that test, the modified barium swallow, is a more functional test to say, well, where is the problem? What is the problem with your swallowing, as opposed to the esophagus?
What are the treatments from
Again, it's a little bit of this physical therapy stuff, the training, the swallowing techniques, and things like that to swallow safely. So that falls under the category of the oropharyngeal, so the swallow mechanism itself up here, as opposed to a cancer issue down low or a stricture down lower. Yeah, so basically the lower esophagus, that lower esophageal sphincter is almost always closed, but then you do have these things that are transient relaxations of that sphincter. And so that's basically a pop-off valve for air that's in the stomach to come up. And so everybody has that, it's normal, and so you have these transient relaxations, and so that's when people belch. And so belching is normal to allow air in your stomach to get out. And so some people have an issue where they have maybe a hiatal hernia, where part of the stomach bulges up into their chest, and they have kind of that lower sphincter. The anatomy has been altered and changed a bit so that you feel that you have air, or you actually do belch and have air in your esophagus. So the air has to come from outside, and it goes in, and then it has to come out as well. Well, so the hiatal hernia can cause it. When you're eating or drinking, if you're eating and talking and you're swallowing air more than normal, then again that air has to come out, and so it's going to come out. It could represent a problem. Sometimes people will, when it's primarily a liquid, that can represent a problem with the motility of the muscles of the esophagus not being strong enough to propel that liquid down. You would think that liquid would go down just fine in almost everybody, but when there's a problem with the muscle contraction, it's more likely a problem with liquid. So there are certain pills that you are allowed to crush and certain pills that you're not supposed to crush. And obviously the ones that you can crush, like multivitamins and things like that, you should just crush those and take them with some liquid or pudding or whatever. The ones that are supposed to be delayed release, shouldn't crush them. They represent more of an issue. And then I think that what I would do in that situation is if it says on the thing, on the bottle, do not crush, you might talk with your primary care about the swallowing issue of that specific pill and see if there's an alternative, or see if you could break open the capsule and swallow the granules inside, or whether that's safe or not. So I would treat that on a pill-by-pill basis. The chin tuck is one of those physical therapy techniques that the therapist will teach with swallowing difficulty. So the chin tuck is definitely one of them. In general, no. In general, it is safe to take omeprazole, Nexium, Prilosec, Prevacid, all these medications. And so every decision that you make with medicine or with your car is a risk-benefit decision that you have to make. And so if you have reflux and you're trying to decide whether you should treat the reflux or whether you're afraid of having potentially decreased calcium absorption over time, well, the ramifications are not equal on those two things. Nobody wants osteoporosis, but also nobody wants esophageal cancer. So you have to make a very unique decision when it comes to you about what your risk factor is for why you're taking that medication and what the potential side effects would be. Now, the long-term potential side effects of medicines like Prilosec or Nexium, it can slightly decrease your calcium absorption. It can slightly decrease some of the other your ability to absorb other vitamins. It can predispose you to certain types of GI tract infections. And so those things are true, but then there's the reason that you're taking it in the first place. So you have to weigh those. But in general, are they safe? Without a doubt, they're safe. Yeah, for sure. Food and lifestyle and body habits all have to do with acid reflux. Things that relax the lower esophageal sphincter, which is the junction, between the esophagus and stomach. So that's the job of that is to keep things closed. And there are certain foods and medications that can relax that: chocolate, peppermint, onions, alcohol, spicy food, greasy food, tomato sauces. The good stuff, right? I mean, that's, lifestyle modifications, and meaning, what you eat and when you eat it, that's by far the biggest thing the first thing anybody should do. And if that approach doesn't work, then always medications are reasonable to consider. So obviously you're not going to avoid all of these foods forever, but just being aware that, like, let's say you're going to go out to dinner, friends and family, and you have a big plate of lasagna, and then you have some chocolate cake afterwards, and then you look at the clock and it's 9 o'clock, you're like, well, I'm just going to go home, we're going to go to bed, it's late. Well, you're probably going to have reflux that night. You know, I mean, that's like the perfect storm. And so it's just a matter of knowing what the issues are, you know. Gravity is our biggest asset when it comes to acid reflux. So when you're standing upright or you're sitting upright, it's hard for acid to come uphill. And so when you lie down or when you get in the recliner or when you bend over, for example, but really it's lying down, you lose gravity. So you lie down and it's like you have a 2-liter bottle of soda with the top turned off. You know, you lie that bottle down and whatever's in there is going to come up or come out the top. And so if you can have 3 hours from the time that you stop eating, and that includes snacks and things like that, 3 hours from the time that you stop eating to the time that you lie down, that's going to set the stage for you to not have reflux. Raising the head of the bed helps as opposed to sleeping on pillows. You know, sleeping on pillows, you know, is helpful for people who have heart failure, but it's not helpful for reflux. And so what you want to do is you want to raise the head of the bed, sleep on a recliner, that sort of thing. The sleep number beds, you know. The wedges, not so much, because what they do is they you know, if you normally sleep flat and then you sleep on a wedge, all of a sudden part of your body is at an angle, which changes this angle, so it's squeezing you in the stomach where you actually don't want to be squeezed. And so to raise the head of the bed still keeps your body straight, but just gives a little bit of gravity there. Yeah. So anxiety and stress create a higher cortisol level in your body, and cortisol is the stress hormone, and so that can produce increased acid, which is the issue with reflux. Stress doesn't cause ulcers, but it can make reflux worse. The guidelines say that if you have reflux twice a week or more, you should be treated for it daily, every day. So if you have heartburn, you know, when you know, on certain high-risk occasions where you're going to have the chocolate cake and the, you know, spaghetti, if that's the issue, then, you know, probably you're okay. But if you're having reflux, you know, Monday and Wednesday and then a couple of times over the weekend, you should probably take something. But if it's less than twice a week, then you're okay to take a Tums or something like that on demand as needed.
Well, thank you, Dr. Schmidt. We
Thank you.
appreciate you coming out, and thank you to all of you coming out and enjoying this with us.
Thank you. Thank you.
Next
Thank you.
Wednesday